Hi, and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor for JAMA Network Open.
I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions or comments on Twitter at JAMA Network Open, or you can send them to us in the comments under the video on YouTube or Facebook. So our first paper today is the association between physician depressive symptoms and medical errors, a systematic review, a meta-analysis, and we've got first author, Dr. Karina Pereira-Lima, with us. Welcome.
Hi, thanks for having me.
Great. Really glad you could join us. So first, tell us a little bit about yourself.
I am a clinical psychologist in Brazil, and also I'm a postdoctoral fellow at the Federal University of São Paulo and a visiting research scholar in psychiatry at the University of Michigan in Ann Arbor.
Great. So tell us, what brought you to this paper? What was the idea behind doing this study?
Sure. What bring our attention to this matter was that we have a large body of literature showing that depression is highly prevalent among physicians. And studies have suggested that these depressive symptoms among these professionals are associated to many negative outcomes for themselves, for example, lower career satisfaction and also suicidal ideation. But also, besides those very serious outcomes related to depressive symptoms to the physicians, there are also studies in the last decades showing that the presence of depressive symptoms in physicians could be associated to negative outcomes to the patients and specifically medical errors. So we were very interested in investigating what was the magnitude of these associations. And for that, we did this systematic review and meta-analysis that was done in collaborations between researchers from the University of Michigan and Memorial Sloan Kettering in the US, and also from the Federal University of São Paulo and the University of São Paulo in Brazil. And we found those 11 cross-sectional and longitudinal studies looking at the associations between physician depressive symptoms and reports of medical errors. Those studies involved more than 21,000 physicians, and we identified a strong relationship between physician depressive symptoms and medical errors, with physicians screening positive for depression presenting a 95% increased risk for reporting medical errors. And after we looked at this strong magnitude, we also wanted to look at the direction of this relationship. So in other words, was depressive symptoms leading to medical errors, or medical errors were leading to subsequent depressive symptoms? And then we did this sub-meta-analysis of longitudinal studies only. And if you look at our figure 3, I think we can find that what we found in there is that not only reports of medical errors were associated with a 62% increased risk for depressive symptoms in the following 3 months, which was kind of expected. We know that making a mistake can be devastating to a physician. But also depressive symptoms were associated with future reports of medical errors in the following months. And if you take those findings together, they strongly suggest that possible efforts to improve the well-being of physicians could also be leading to a safer environment to patients.
That makes sense. I thought it was very, very interesting and super relevant to, I think, more and more in the literature, but also just in discussions, we're sort of recognizing that there's potentially this association. One thing I wanted to ask you about was sort of any difficulties you encountered. I think when you talk about depressive symptoms and even errors, there is a potential for some subjectivity there. So I wonder kind of if you encountered that and how you accounted for that and how that played into the potential heterogeneity you ended up seeing between some of the studies.
Sure. Yeah, no, that is a very interesting question. So definitely we have a need for more studies assessing objective measures of medical errors. Most of the studies included 10 of 11 studies looked at self-reports of medical errors, we have some previous research in the literature showing that those self-reports of medical errors, especially major medical errors, are very highly correlated with actual errors. But we do need more studies investigating whether those associations would also be finding with those objective measures. But I think like when we look at those longitudinal associations that measured both depression and also depressive symptoms in different time points, and they were still associated, that tells us something about the possible existence of those relationships. And regarding the depressive symptoms assessment, we we included instrument studies that were using validated instruments for the assessment of depressive symptoms. But also, like, we need to acknowledge that what we saw in there was an association of depressive symptoms and not a clinical diagnosis of depression, since they were not clinical interviews.
Right. Yeah. Well, and it's tough because there's so many barriers to physicians even getting diagnosed with depression when they have it. Not just the hours worked, the time away from family, et cetera, but also just, if you get diagnosed, you have to, report it on licensure applications and things like that, which is a whole big mess. Yeah, I really like the way that, this is obviously a complex study. There's never going to be an RCT randomizing people to commit medical errors and seeing if they did develop depressive symptoms. So looking with this observational data and trying to suss out the bidirectionality of the association was really just fantastic. I like that.
Yeah, I did too.
Yeah. So what are the next steps?
So yeah, I think like we identified here some very important steps for next research, and one of them is, of course, to look whether interventions to reduce depressive symptoms could also mitigate medical errors, since we find this longitudinal association. I think this is very important. We also found that most of these studies were made in the US, so maybe studies in other cultures could also bring some light on specific aspects from the culture and from healthcare systems that could be leading to the development of depressive symptoms and those associations. And the objective measures too, like we need to figure different ways that we could measure and assess those medical errors that are in a reliable and also objective measurement.
Great. Well, we want to welcome viewers Estella Azika and Greg Pauly. We're talking about the association between physician depressive symptoms and medical errors. One of the other things I was curious about is I wonder if there's any data, and you might not know, or this might be a future area of study, on whether or not there's ways to mitigate physician reactions after medical error, like if it's a more positive, supportive system on dealing with medical errors versus, just, oh, this bad thing happened and, there's an M&M and people yell at each other and that's it.
No, yeah, I think like we found bidirectional associations here. So definitely thinking about how to talk with the physician after medical errors and how to proceed with that and have the support system. And also like how to monitor those physicians who are at depressive symptoms in a way that is not like disencouraging them to report that, so they can get the treatment they need and the support they need to deal with their symptoms. But,
I wonder too, actually, that just makes me think about the fact of whether or not the magnitude or the perceived magnitude of the error makes a difference at all. I'm sure there does, not to say that, every error is obviously a concerning thing, but I feel like there's all of these factors that come into play that are probably difficult to measure, as you probably saw.
Yeah.
So I think it's difficult to do this kind of work, so I'm very impressed that you're able to do it.
Yeah, no, thank you. No, you were right. Like, yeah, most of the studies, they look at major medical errors. We had some studies that looked at any type of medical errors too. I think one study asked about any error. Other study, they looked at medication errors, whether they were harmful or not, or potentially harmful or not. But the others, I think, like all the others, they asked the physicians about major medical errors. So they didn't provide a definition, but were errors that were internalized to them as a major one. So,
yeah. Well, great. This is really great work. We appreciate you coming on and talking with us about it, and keep up the good work.
Thank you. I really enjoyed talking to you too.
Great. Absolutely. Take care.
You too. Bye.
All right, going to welcome another viewer, Joe Solis. We're moving on to our table of contents. Welcome. So first up, we've got this interesting paper looking at the association between acute gastroenteritis and continuous use of proton pump inhibitors. Proton pump inhibitors are, incredibly commonly used, mostly for GERD, gastroesophageal reflux disease, and are generally considered pretty benign, but I think we're slowly accumulating some kind of long-term potential adverse effects. And what they did in this study was they looked at a database of 7,000 French pharmacies, which apparently distributed across France pretty well. They used this validated algorithm because they only had prescription data, no clinical data.
Yeah.
So they used this validated algorithm to estimate rates of gastroenteritis, basically, where people getting things like anti-nausea medications, anti-motility medications like loperamide, based on diarrhea medicine, et cetera, to estimate prevalence or incidence, of gastroenteritis, and then looked at patients in the database who had who were on continuous PPI use, so long-term chronic PPI use, and basically found they had about nearly twice the rate of gastroenteritis. So obviously this stuff gets complicated, and they tried, the risk did stay high even after adjustment for comorbidities, but they're using administrative data, so it's hard to know, is it just sicker people get sicker, more likely to get gastroenteritis, et cetera, if you're somebody who's, has GERD. But definitely I think is one more little, I think, strike against long-term PPI use.
I know, it's it's so true. More and more, I think we're finding out that there are potential risks to long-term PPI use, and so there certainly calls for more stewardship from that perspective. I do think it's sort of interesting if you think about it. I mean, if you're on a long-term PPI, certainly you're suppressing, you're having this acid suppression, and certainly there must be some mechanism by which you are messing around with the microbiome. So I think it kind of makes sense intuitively that, there would be some outcome, but I do think it is sort of interesting to think about the various ways in which this could manifest itself.
Right. Yeah. And I could hand wave around the physiology a lot. How much of it is stomach acid, part of our immune system, impacting the microbiome, or the exposure to, say, norovirus, or is it just people with GERD are unhealthy and more likely to be, like they had rates of 20% diabetes versus 15%, for instance. Also, one thing that's interesting, they also looked at H2 blocker use, because those are similarly used for GERD, and basically found a pretty similar rate as well. So there's something there, maybe. Something seems to be going on. So certainly hypothesis generating, as we say. Do you want to recommend? Karina's joined us. Welcome. Glad you're following along. Welcome back. As well as the Universidad Federal. And we're moving on to, what do we have next?
This is the association between marijuana use and risk of cancer, systematic review and meta-analysis. So this was trying to look at the association of ever use of marijuana and the development of certain types of cancers. So this looked at 25 studies, and it was interesting. They did pooling of case control studies that they found, looking at the ever use of marijuana, and they found that this was not associated with head and neck squamous cell cancer or oral cancer. Then they pooled 3 of these case control studies and actually found that having more than 10 years self-reported history of marijuana actually was associated with an increased risk of testicular germ cell tumor. And specifically, this was for non-seminomatous germ cell testicular tumors. And so this is actually figure 3, you can see some of these associations. Other cancers that they looked at, lung cancer, this was sort of mixed. There was a lot of confounding here, so they couldn't really make a conclusion based off of this. They do note that this was ultimately sort of low strength evidence because a lot of these were observational studies, but still there wasn't that much heterogeneity actually when you looked at the pooling that they did. So that was sort of encouraging. So sort of an interesting, I think, again, there's a lot about talk about marijuana, in media and even in the medical world about long-term kind of consequences. This is another thing to potentially think about.
Yeah, it's certainly interesting, and it's tough because, we know a fair amount about tobacco smoke and how dangerous it is. And one of the big studies, especially in lung cancer, is that a lot of the people who smoke marijuana also smoke tobacco products,
right,
which makes it really hard to disentangle those two. So it's really interesting, and then they tried to look at just marijuana only smokers, but there's not as many of them, et cetera. And basically, what they end up with these really wide confidence intervals. Like the point estimate for germ cell tumors was a relative risk of 3.2, but the confidence interval is 1.1 to 9.2.
Yeah.
Yeah, and for daily users and for monthly users, 1.3 to 10.2.
Right.
That's a more than threefold difference.
Right.
In the confidence interval. So that's broad stuff. But it's interesting, especially as more states are legalizing recreational medical marijuana.
Yeah.
It's certainly salient.
I think so, and I suspect we'll probably see with that, change in sort of policy. We'll probably see more studies down the line to kind of look at these long-term risks.
Yeah, absolutely.
And benefits.
Exactly. Welcome, Patrick M has joined us. We're moving on to now an interesting paper where they looked at diabetic retinopathy, visual acuity, and treatment outcomes for patients with diabetes in Bangladesh. And this is a really interesting study where they so there's a pretty high burden of diabetes in Bangladesh. There's some pretty big access to care issues and some resource issues. But in 3 hospitals in Bangladesh from 2010 to 2017, they were able to get patients into this diabetic retinopathy screening program where they dilated their pupils and used fundus photography with mounted cameras. And we got some pictures of some of the fundoscopy pictures here. And they're just brilliant pictures of some pretty bad diabetic retinopathy, which is sad stuff. And one of the other things that was really interesting about it was they were able to use this tiered process of non-physicians who were grading the images. It was nurses, optometrists, and paramedics, and only basically use the ophthalmologists to differentiate or I'm blanking on the word, but to figure out when the
severity or
when there was discrepancies between their assessments, and because they're using these digital cameras, they are able to do offsite basically telefundoscopy.
Yeah. So were they actually? I didn't understand the process actually. They were using phones or photos?
They were using it was digital cameras that they used, or some sort of digital cameras they used to do the fundoscopic pictures.
Right. Okay. And then sending those. Okay, that makes sense. I really like that. I mean, I think that's sort of a pragmatic, practical approach. Particularly in lower resource settings, when if you're trying to improve your screening, being able to use other types of providers is so useful. Yep,
absolutely. Yeah, other types of providers, and also using telemedicine to kind of expand access to specialty care.
Absolutely,
it's a recurring theme that we see in a lot of our global health and rural health papers here. And what's really interesting is they're talking about the rates of blindness in Bangladesh are approaching 2%. It's pretty high.
It's high.
And then, not surprisingly, the Helen Keller International is a member of the task force the Bangladeshi government's partnering with, which is really great. And also a reminder that Helen Keller was actually a pretty outspoken advocate for basically improving access to care and other stuff for poor patients, for poor populations, recognizing that blindness is primarily a disease of poor people, disease of poverty. Interesting stuff.
Very interesting.
So her great work continues.
Yes.
Her legacy moves
on.
Absolutely. Right. So next up, another interesting one. This one's not in Bangladesh, but Michigan. So they looked at costs associated with modifiable risk factors in ventral and incisional hernia repair. So this was 73 hospitals in the Michigan Surgery Quality Collaborative, a database that basically puts together surgical outcomes in the state of Michigan. They looked at nearly 23,000 patients from 2012 to 2018. It's about 900 surgeons who were operating. It was for ventral and incisional hernia repairs. Most of them were open repairs. They found they had a 4% complication rate, 2% overall were serious. There was a nearly 8% ED visit rate in 30 days, and about 4% of patients needed to be admitted to the hospital after their surgery. And they found, not surprisingly, risk factors for some of the bad outcomes were higher BMI, insulin-dependent diabetes, open surgery, and patients who needed to be inpatient, which is not surprising because that's kind of by definition.
Yeah.
And basically, when they calculated the costs, I'm just going to quote their numbers here. So additional spending for a serious complication after surgery was $26.6 thousand, of which $3,600 associated with morbid obesity, $650 associated with insulin-dependent diabetes, and $570 associated with unhealthy alcohol use. And the upside is obesity, diabetes, and unhealthy alcohol use, as well as smoking, are all potentially modifiable risk factors. So areas where we could take better care of patients and potentially save money?
Yeah, I think it's interesting thinking about this kind of thing, particularly from someone who used to do sort of preoperative evals. I think a lot of these risk factors are things that we kind of know or are intuitive at least, but it is interesting to think about it, to look at it in this way and consider this kind of moving forward. The one thing I wanted to ask you about actually was this discharge not to home. I was surprised with that and wanted to know if you had any thoughts about it.
Yeah, I'm not sure. I wasn't exactly sure what they mean, but some of that language oftentimes means when patients are kept in the hospital for observation or something like that. And it's just you can't say admitted because they're not technically admitted because that means very specific things.
Yeah.
We actually, a couple of years ago, when we get our quality metrics from my emergency department, we used to get our admission rates, but then we recognized that I think 60% of our hospitalized patients are observation from the ED.
Okay.
Whether that's in the ED obs or in the inpatient obs, which is not a word or not a term. But yes, we changed it to not discharged.
Oh,
because,
I see.
You just have to talk about the negative. Just because in observation can mean two different things. It can mean clinical obs, like let's give you another 6 hours, make sure that you don't need more nebs or anything else for that asthma, versus short inpatient or short hospital stays where it's basically just like a junior DRG.
Oh, I see. Yeah. Okay.
Observation stuff gets complicated. Welcome a couple more people. We've got Rodrigo Lagrasta and John Perry. So welcome. What do we have next?
Okay, so next we have a research letter. It's the assessment of gender equity among invited speakers and award recipients at U.S. annual medical education conferences. This was a cross-sectional study that looked at AAMC and ACGME award recipients and invited plenary and keynote speakers to try to assess gender parity, and this was between 2010 to 2019. They looked at 20 conferences overall. They found that 29% of invited speakers were women, and there was no significant difference when you looked at it stratified by conference. This is in Table 1. You can see the breakdown of this. And that only 27% of award recipients, AAMC and ACGME recipients, were women. It's interesting because they actually break those awards down further, and they found that women were most represented in the Arnold P. Gold Humanism in Medicine Awards and the Park G. Palmer Courage to Lead Awards. And they kind of just talk about this a little bit in the discussion about the sort of, it's not really an association, but this perception that sort of topics that are more conceptual or related to humanism and medicine tend to favor female recipients. But, so it kind of was borne out in this way, I guess, we saw in here. So I think another one of, I think we've been seeing a few of these kind of papers looking at gender parity and gender equity among various sort of components of academia. So this is just another thing that shows, unfortunately, disappointing numbers. But hopefully you have something optimistic here to say.
Yeah. So, I mean, and one of the things they point out is that women medical school faculty at the beginning of the study period was 36% and has increased to 41%.
Yes.
So overall, the 27%, some of this might be inertia from before a time when the inequities were even worse. So, there's certainly room to improve. And frankly, I thought there was going to be a bigger gap between the kind of prevalence of women in medicine and the awards and speaking. They're still disappointing numbers.
Sure.
And we know we've seen it's that pipeline picture with all the dripping coming out and the pipe getting smaller and smaller. That the ratio or the proportion of women in medical school, which is I believe like 52, 48, and then in leadership positions and deanships and things like that, first author, writing invited commentaries and things like that, it just gets smaller and smaller. So lots of room for improvement.
Absolutely. There we go.
All right, we got one more. What's up?
Okay, so this is another research letter, Patient Perspectives on the Cultural Competence of U.S. Healthcare Professionals. This was a survey study from the 2017 National Health Interview Survey, included more than 22,000 patients, and these were 5 additional questions asked to patients regarding their visit that had to do specifically with cultural competence, or cultural competency, I should say. They found that 35% of respondents overall reported that healthcare professionals did ask them at some point during their visit about sort of their opinions or beliefs about their care. and about 22% said some of the time their healthcare professionals asked them these types of questions. Interestingly, 51%, so a little over half of respondents said that sharing one's culture with their healthcare professional was actually important, or was not important, I should say. So less than 50% said it was important. And then they kind of broke this down further, looking at race and ethnicity. They found that Black, Hispanic, and other race and ethnicity patients were significantly less likely to report that healthcare providers treated them with respect most of the time or always. And this was actually a similar trend seen among uninsured or low-income patients as well, unfortunately. So I like these studies because you kind of get a glimpse into sort of patient perspectives, which I think is really important. But unfortunately, the results to me were a little bit disappointing.
Yeah. So on that note, gonna welcome Ora Laram, who has joined us. Welcome. But yeah, it's, I mean, this research letter, even though it's short, is a roller coaster where it's like, hey, look, it was something like 95% of respondents thought that overall they were treated with respect, but not surprisingly, it was non-white, low-income, and uninsured patients were less likely to report being treated with respect.
Yeah, and it is sort of interesting because actually I think that the majority of the patients that actually responded to the survey were identified as white or non-Hispanic, so certainly that plays into it a little bit in terms of the sample size, but yeah,
but it's unfortunately if you just look at how the majority does, then
yes, exactly,
that's how we end up where we are.
Yes.
Right. So again, lots of rooms for improvement, and again, the fact that we're paying more attention to this, asking questions in big national surveys of 77,000 respondents, something which is big numbers. So
yeah,
good stuff. Seem to be moving in good directions, which is nice.
Thank you. I love that. I love being able to end on an optimistic note.
All right. So on that note, join us again next week, 3 p.m. Tuesday Central Time. We'll talk about a whole bunch more papers. You can find these papers and more. Everything's free open access at JAMAnetworkopen.com. New papers come out tomorrow, Wednesday, and Friday at 10 a.m. Central Time. And of course, follow us on all the usual places. And you can get the author segment of these sessions as audio wherever you get your podcasts. So take care.
Bye.